Okay, so after the first sentence of Dr. Adir, who said there is no debate, so there's no debate, so I may finish here. Yes, when we go home. But anyway, I will continue, and actually, after saying no conflict of interest, my first slide was there's not much of a debate. Because this is a mechanical problem, and mechanical problem need to be solved by a mechanical solution usually. And the but I will keep for the later, further in the talk. And initially I will start by describing this relatively neglected disease. Some is similar to Yochai, so it will be faster. So I think he showed this slide before. Out of about 300 patients with acute pulmonary emboli, by 2 years, only about 4% developed chronic thromboembolic pulmonary emboli. So this is a relatively not frequently seen disease and tend to be neglected. And risk factors for the problem we heard before, acute pulmonary emboli, chronic inflammatory disease, coagulation disorders, and so on and so forth. The natural history of the problem is development of pulmonary artery occlusion, and then elevated pulmonary vascular resistance, elevated pulmonary artery pressure, PO2 decrease, then RV fails, and eventually the patient died. The clinical features, the hallmark is that there is a latency from symptoms onset to diagnosis. Usually there's a gradual onset of shortness of breath. The clinical signs are subtle, and because of the lack of awareness of the disease, initially the patient will be diagnosed as having asthma, left ventricular dysfunction, and other problems. And it takes usually 2 to 3 years of delay until the diagnosis is being made. And I think the hallmark of the talk is actually this slide, the histology. This is not a blood clot. I mean, and the obstruction of the vessel is the combination of fibrous organization incorporated into the vessel wall and remodeling of the small vessels. So again, this is a mechanical problem, and mechanical problems requires mechanical solution. I don't think anybody in this audience will think that medical treatment is the treatment of choice for papillary muscle rupture, acute VSD, rupture of the free wall or aortic stenosis, and I think this is just similar. And if we look at the prognosis of chronic thromboembolic pulmonary hypertension, you see it's really correlated with the pulmonary pressure. And above about 30 millimeters of mercury mean pressure, the long-term survival, the natural history of the patient is very bad. If a patient has higher than 50 millimeters of mercury, practically by 6 years, all of them are dead. So how do we select patients for pulmonary thrombo-endarterectomy? First of all, the patient needs to have symptoms, and we need to look at the prognosis. So we need to show thromboembolic disease on imaging. Usually the patient will be referred to operation if they are in class 3 or 4, and in some very experienced centers in the world now they start to operate also on class 2 patients. The patient, we need to document significant pulmonary hypertension and obviously elevated pulmonary vascular resistance, and age and comorbidity. And again, comorbidity are really a very important player in the decision making. And again, the subject of this talk was ICU's chronic thromboembolic pulmonary hypertension. I was puzzled by what are the ICU, because this patient who are referred for operation need to be stable patient. This is a huge operation, and there is no room for this operation in acute patients. So anyway, I tried to deal with the ICU chronic thromboembolic pulmonary hypertension. So who are they? Those usually probably will be the patient who has acute on chronic. So it's a patient with chronic thromboembolic pulmonary hypertension that have now an acute pulmonary emboli, and he deteriorates. This is not a patient for surgery, so this is the but. He is not a surgical candidate. We need to take care of the pulmonary emboli in a regular manner with thrombolysis or whatever cause, and if he will recover and if he will stabilize, then he might be a candidate for surgery. And the others probably are the end stage patient with chronic thromboembolic pulmonary hypertension, which are also not candidates for surgery. So the investigation we heard in the previous talk, but first of all, the patient needs to be referred. And this is, we talked about neglected disease. Many patients are out there that are not diagnosed early enough and probably miss good operation and prognosis with surgery. So patients need to be referred. Then they go a bunch of testing, exercise testing, echocardiography, pulmonary function test, VQ scan is very important, obviously, and right heart catheterization. So patient undergo VQ scan. If there is no perfusion defect, there is no CTEP. They need to have perfusion defect, and then we like to have at least 2 out of these 3 modalities to show us the extent of the disease. So it might be CT angiography, MRA, or pulmonary angiogram, and only then a multidisciplinary treatment will be discussed. And we saw it before. We have the VQ scan, we have the angiography, MRA, and CT scan. All are good modalities for investigation. Only then we go to the phase 2 investigation, which is coronary angiography and carotid Dopplers, since many of those patients may have coronary artery disease, and then we need the coronary bypass in addition to this operation, and the carotid Doppler for risk stratification. Now we heard about the insertion of the IVC filter. There is no conclusion, but most places, most of the people believe that this is indicated preoperatively in order to prevent future acute pulmonary emboli in those patients. Now the group from San Diego, which is the leading group probably in the world, suggested 4 types of pulmonary hypertension, or of chronic thromboembolic pulmonary hypertension, and accordingly the results of the surgery. So type 1 and type 2 are proximal disease, and type 3 and 4 are more diffuse and distally disease. So type 1 is fresh thrombus in the main lobar pulmonary arteries, and type 2 is intimal thickening and fibrosis proximal to the segmental arteries. Type 3 is disease within distal segmental and subsegmental arteries, and type 4 is vasculopathy of all the vessel bed of the pulmonary arteries. And you can see this example 1 and 2 are proximal lesions, and 3 and 4 are distal lesions. And indeed the results can well be predicted by the type of the disease. Because the type 1 and 2, the proximal disease, you can achieve very good results. You can see the decrease from the preoperative pulmonary pressure to the postoperative pulmonary pressure, and the mortality is relatively low. However, when you have a type 3 and 4, the end result is less remarkable. Pulmonary pressure is not getting down as good, and the mortality is much higher. And if you look at the 2 probably largest and more active programs in the world currently, the San Diego one and the PAPFOS from Cambridge, England, you can see relatively similar patient population and results, similar age, similar circulatory arrest time. I will talk about it later. In hospital mortality in about 4 to 5%, a nice decrease in pulmonary pressure, and the PVR comes down very nicely. And see the numbers, the PVR that they operate upon are about 800 to 900, and that's important. We'll see in a second. If you are looking at the long-term result of those patients, you can see that by 10 years, if you properly select your patient, almost 90% are alive, and this is remarkable. And we saw this slide earlier by Dr. Adir, and this is the PVR. We know that there is a pre-op, that pre-op PVR predicts the mortality after the operation, and above 1200 is considered excessive. And again, who are those patients that have the very high PVR? It's either type 3 and 4 patients, or the acute ICU patients, which are the end stage or the acute pulmonary emboli on top of the chronic disease. So these are not good surgical candidates. Now the surgical technique is after the San Diego group. Usually we do a median sternotomy to approach both lungs. We get into the pulmonary arteries intrapericardially, but we need to go all the way into the segmental and sometimes subsegmental sections of the pulmonary arteries. Because of a lot of collateral flow, they have a very large bronchial arteries, these patients. So we need to put the patient on cardiopulmonary bypass, cool the patient to what we call deep hypothermic circulatory arrest. And then the major trick of the operation is to find the right plane in the vessel wall, because this is not an embolus. It's incorporated to the vessel. And if you are not in the right plane, you're either too superficial and then you won't do a good job, or you're too deep and then you may rupture the vessel, and this is disaster. This is just a scheme of how the procedure is being done. And that's a view inside the pulmonary artery before. You can see nothing, but you can see it's not really a thrombus. It's something that incorporates all the vessel. And then how it looks after the thrombo-endarterectomy. These are 2 samples of real-life patients, type 1 patients. What is the cause of death perioperatively? So usually it's residual pulmonary hypertension and RV failure. And that's secondary to either inappropriate case selection, as we say, type 3 or type 4, or patient with too many comorbidities or too risky patients, like ICU patient in acute phase. The patient may have reperfusion lung injury. We heard before. The vessels that were not occluded preoperatively are undergoing remodeling, and the pulmonary vascular resistance over there is high. After we're doing a thromboendarterectomy, all the flow will go, most of the flow will go to the denuded vessels, and a picture like pulmonary edema-like will happen. So the post-operative care of this patient is very difficult and very demanding. It may go into multi-organ failure, and obviously technical error can cause death as well. So what is the take-home message? Pulmonary thromboendarterectomy is the most effective therapy for stable chronic thromboembolic pulmonary hypertension. Advanced medical therapy is considered in patients with inoperable disease. Among preoperative predictors of favorable outcome are the absence of major coexisting conditions. Pulmonary thromboendarterectomy is seldom reported and is not the treatment of choice of unstable chronic thromboembolic pulmonary hypertension, and acute pulmonary emboli on top of chronic thromboembolic pulmonary hypertension should be treated as acute pulmonary emboli and reassessed again when stable. And not much of a debate, as I said. Thank you very much.